So minimal residual disease is becoming very important in ascertaining the major response to treatment in chronic lymphocytic leukemia. We have been looking at minimal residual disease for a long time, especially in the chemoimmunotherapy era. It's quite clear that patients achieving very deep MRD negative remissions do very well in terms of progression-free survival and overall survival. So the data has been presented at multiple meetings before, and any patient who's achieving deeper MRD negative remission sees an overall survival and progression-free survival difference. What I'm going to talk about is what is the relevance of minimal residual disease in the new era, which is the targeted drugs. And essentially what we are finding at the moment is that patients achieving deeper remissions are staying in remission for a longer period of time, even with targeted molecules. This is slightly different for B-cell receptor antagonists like ibrutinib, where continuous therapy is still given. But now there are two kind of roles of MRD that are being developed in treatment of CLL patients with targeted molecule. One is achievement of MRD negativity with finite therapy, and there is two good trials now at the moment, both phase 3 trials. One is frontline trial called CLL14, where patients were randomized between venetoclax with obinutuzumab versus chlorambucil with obinutuzumab. And venetoclax was only given for 12 months, and it is very clear that the combination of venetoclax with obinutuzumab is very potent, and nearly 57% of the patients achieve MRD negativity in the bone marrow at 12 months. But the unresolved question is that after 12 months, nearly more than half of the patients are becoming MRD negative. What will happen to the MRD positive patients, because it is just finite duration of therapy? Similar data was presented in a relapse setting, which is the MURANO study. And MURANO study was looking at giving venetoclax with rituximab for 2 years, and that's again finite duration of therapy. Again, patients who achieved deeper MRD negative remission at 2 years of therapy did extremely well and continued to do extremely well without any further therapy. And we have seen the 3-year data at ASH last year, certainly telling us that MRD low patients are going to do fine, whereas the MRD high patients are most probably going to relapse. So it is becoming a very important prognostic marker in that setting. The second concept now is defining the therapy based on individual patient's response. So if a patient, the best example for that is CLARITY study, where we are combining ibrutinib with venetoclax, and a patient who becomes MRD negative at 8 months of combination therapy will stop therapy 6 months later. And the patients who became MRD negative at 12 months of combination will continue for another 12 months of therapy and then stop at that point. So it is tailoring the therapy based on individual response. Whether this is the right approach to take, or whether finite duration of therapy is the right way to take MRD forward, is still to be seen, and over time we will know the answer.